Hello and welcome to Alexander Disease Research Update, episode number 35, recorded on August 21st, 2026. I'm Albie Messing from the Waisman Center at the University of Wisconsin, and with me today is Dr. Aidan Long, who happens to have been a longtime member of the faculty at Harvard Medical School, but that's not why he's here today. And I should say right at the start, this is going to be a very different type of podcast from our usual ones. We're not going to be talking about the latest results or model systems or new variants or new ideas about treatment. Instead, we're going to be talking about families and the experience of learning that you might be dealing with Alexander disease. There's nobody better able to talk about this with us from multiple perspectives than Aidan. He's not only a physician, but as he found out several years ago, a patient as well. And he's taken the trouble to write about his experience in an article that is now in press in the Journal of the Neurological Sciences entitled Demonstrating Clinical and Radiological Variability of Adult-Onset Alexander Disease in 3 Siblings. Before we get started, please send feedback and questions to my email at amessing@wisc.edu. Aidan, since this is your first time on the podcast, can you tell us a bit more about yourself?
Yes, thank you. So I was, prior to retirement, a practicing clinician at an academic medical center in Boston. My field of specialty was allergy and immunology. I received my medical training and residency in Dublin, in Ireland, and that was followed by a clinical and research fellowship in allergy and immunology in Canada at McMaster University. After that, I moved to Boston for a further 4 years of laboratory research, and since that time, I've been working as a full-time clinician in academic allergy immunology in Boston. I spent 12 years at Tufts University Medical Center and the last 20 or more years at Massachusetts General Hospital, which is part of the Harvard Medical School system. In that role, I was a full-time clinician, but I also served as the training program director for allergy immunology for most of that time. My field of expertise is probably management of severe asthma. And so as you can see, even though I'm a physician, I was not well versed in issues related to neurology or issues related to genetic diseases.
Well, thanks very much for being here.
My pleasure. Thank you.
Perhaps the best way to begin is for you to tell us how you first learned that you might be dealing with Alexander disease.
Yes, it was actually accidental. I was under investigation for a febrile illness. During that course of investigation, a phrenic nerve palsy or paralysis of the left side of my diaphragm was identified. And in the workup for that, I had a neck MRI. The MRI came back showing no issue with the vertebrae around C3, 4, and 5 that feed the phrenic nerve, but instead it showed a narrowing of the medulla oblongata extending into the upper cervical cord. Now, this was not reported as Alexander disease, it was just described for what it was, but it occurred to me at that time that 2 of my siblings in Ireland were also dealing with issues in their brainstem or cervical cord separately from each other. And I reached out to them and asked them to send me the results of their own MRIs.
We should say what ages you all are around this time.
So at that time, it was 2021, and I was 66. I had an older brother who was 68 and a younger sister who was 63 or 64. So we're all in our early to mid 60s. Now, they had been dealing with predominantly balance issues and walking issues for several years. And I knew they'd been under investigation, but that there was no clear diagnosis. So I asked them to send me their MRIs, which they sent me the reports, And when I saw them, I was struck by how similar their results seemed to mine. In each case, describing significant narrowing of the medulla oblongata with some extension into the upper cervical cord, and also a phenomenon on MRI known as flare or increased signal intensity seen around the medulla oblongata. So lo and behold, we had three of us who had very similar MRIs and had not been aware of a clear diagnosis before that. I should say that in my case, I was not aware of any clinical symptoms related to my cervical cord or medulla oblongata. So I began to look up the literature to see if there was any condition that might cause a familial problem characterized by these radiological abnormalities. And lo and behold, I stumbled on this condition, Alexander disease. And therein hangs a tale.
And your parents, what about your parents then?
Yes, so in discussing with my siblings then, we came to appreciate that our father had spent, he died at age 66, but had spent the last 5 years of his life essentially wheelchair bound due to spasticity of his lower limbs. At the time, he'd been under the care of a neurologist, and his condition had been ascribed to osteoarthritis of the cervical spine. And we had a younger brother who had also passed away with severe balance problems, which had been ascribed in his case to alcohol use disorder. But it may be that there was something else underlying both of those. And we all firmly believe that it was Alexander disease.
Do you know anything about your grandparents?
Very little. We have asked extensively amongst our extended family, and the only possible link is that my father's mother was reported as being quite immobile, suspend her life sitting in a chair, and was very overweight. Now, whether that represented a neurological problem, we don't know. She didn't appear to have any other reported symptoms other than being not very mobile and being very overweight.
So this is the usual way of going about filling out a family tree. Did your father have any siblings?
He did. He had 4 or 5 siblings, and there was no suspicion in any of them of a neurological disorder.
How did you then go from suspecting that it might be Alexander disease to actually getting clarification and a diagnosis?
Yes, so I work at an academic medical center in Boston, Mass General Hospital. I sought out a neurology consultation there and essentially presented to them saying, I think I might have Alexander disease. Can you help me diagnose it? And I'd actually done this by email. So I'd forewarned them that I was expecting this diagnosis. So the neurologists were fairly well versed with it by the time I got into the office. And essentially, we sent off genetic testing, and it came back with a variant in the gene for GFAP, an unusual variant, a position 385, substitution of cysteine for serine, which had been described but was known as what they called a variant of unknown significance rather than a pathogenic one. And I then yes, it was positive for this variant of unknown significant. And I arranged that the company that I had used for diagnosis send buccal swab kits to my siblings in Ireland. And those results also came back with the same variant. So at this stage, with what looks like pathognomonic radiology and a variant in GFAP, I think we're pretty clear on the diagnosis in all three of us.
What motivated you then to write about it?
So I was struck by there were a number of reasons, but the dominant one was how few people, including neurologists, seem to know much about this condition. So I felt there was a need to get more information out there. not only to the general medical public, but to the neurology community as well. And I thought there are a number of, secondly, I thought there are a number of factors of our family history that to me were striking and were not something that I had come across in my reading of the Alexander disease literature. Firstly, the clinical variability within a kindred. So three of us had almost identical radiology, had the same gene variant, but had experienced very differing clinical courses. The types of problems we were experiencing were similar, but the degree was very different, and we can go into that. So there was the clinical variability. Secondly, we had longitudinal data in our that we're able to report in our case series showing progression of the radiologic and clinical abnormalities over time. And thirdly, the third clinical issue that I thought was worth describing was what I believe was a some degree of correlation between the clinical manifestations and the radiological abnormalities in terms of degree, i.e., that sibling with the most severe radiological picture also had the most severe clinical picture. And finally, from reading the literature and from just thinking, I became convinced this was a significantly under recognized condition and likely very significantly underdiagnosed. So I felt somehow compelled to put something into the literature to make people more aware of it, that they might think about it more, and also to describe our particular family trio.
Well, let me ask you from your perspective as a physician, and your field is allergy and immunology.
Correct.
In daily practice, I imagine you have to begin by thinking about the most common conditions. And if you start your encounters, and you're at an academic medical center where you're getting people referred to you after they've had problems with a diagnosis, but if you begin coming up with a list of possibilities with rare conditions or ultra rare conditions, it must be an incredibly long list. So how do you balance this challenge as a clinician between dealing with what's most likely the cause of the problems that the person in front of you is dealing with versus what are the theoretical possibilities? That must be a challenge.
I think you said it correctly. You know, common things happen commonly. That's an adage in medicine, an adage in life, actually. And so you very quickly make a survey of the common conditions and see if this adequately answers all of the questions before you. And if it doesn't, then you begin to look further. I think the difference in my particular case as a patient was that I was not really aware of having many clinical problems. To qualify that, I was a little bit unsteady on my feet. I had, I'm an active individual. I like to cycle. And I found cycling through narrow gaps very challenging. And I'd made a couple of attempts in my life to stand up on a paddleboard or stand up on a windsurfer and was a dismal failure. And I just thought, this is either part of just being a klutz or just normal aging.
Mm-hmm.
Not looking back, I wonder if in fact these were early signs that I was having balance issues. But so in the medical encounter, I wasn't asking for an explanation for my symptoms. So it's different from the question you posed. How would you go from symptoms to a rare diagnosis? In my case, there really weren't any symptoms I was trying to find. In my siblings' case, they had both seen neurologists separately from each other and different neurologists and had been told, yes, there are balance issues. We don't really know what it is. We don't have a firm diagnosis. And there was no plan to do additional testing. So they were both being seen in Ireland, whether the approach to treating people in their 60s aggressively or looking deeply is different there than it is here is a possibility. But I think had I been in their shoes, I wouldn't have been happy settling for that sort of lack of inquisitiveness is
Right.
the kindest word I can use.
So the other challenge in dealing with the adult onset category of Alexander disease has always been this issue of, I guess the medical term is comorbidity, that especially as we get older, we have multiple things going on, each of which could be causing problems. Even in your case, the weakness on one side of your diaphragm may or may not be related to Alexander disease. We really don't know. So I think that that also becomes a challenge for everyone trying to decide when it's actually the result of this disease as opposed to something else that might be going on.
Correct. I mean, it's interesting you bring up the diaphragmatic problem. I, at one level, fully believe it's part of Alexander disease. Yet when I look into the pathology and what's known, I have to conclude that it's unlikely.
Mhm.
My MRI of the neck didn't show any extension of disease into the lower part of the cervical cord, not below C2. When I look at the pathology of peripheral nerves, even the demyelinating ones that contain GFAP, there's not much reason to think it would cause such a complete loss of function of the phrenic nerve. There's no reason to believe the Alexander disease is extending into the spinal cord to the anterior horn cells. When I looked back at my phrenic nerve stimulation study, there was a complete absence of response on the left side and a very brisk with a short latency and a very big amplitude response on the right. So a massive difference between the two sides and a complete loss on the left. So it wasn't that it was diminished or not functioning properly, it was dead. And so intellectually, I have to believe it's unrelated.
Right.
Even though it's a problem likely beginning in the neck and this was a disease in the neck, I just don't see it. I'd like it to be part of it. I can't
Right.
bring myself scientifically to accept that it is.
So let's turn to your family. How was all this news received by your siblings?
So my affected siblings, I think, were very pleased to get a firm diagnosis. No doubt about it. They were much happier to be told there is a particular condition that's causing this, and we know something about it. Naturally, they were not pleased to learn that this was labeled variously as neurodegenerative, progressive, and that there was no specific intervention or therapy that would alter the natural history of this disease. I think they probably knew that anyway without this label, but to have that confirmed was probably a bit depressing for them. But I think the biggest impact for all of us was the knowledge that this was an hereditary disease and inherited in an autosomal dominant fashion. Now, each of my siblings and me each have two children. And so the idea that this may have been passed on to the next generation was probably the toughest aspect of receiving this diagnosis. I don't think if any of us were unduly troubled by the fact that we were going to go forward with balance problems, walking problems, maybe other. One dominant feature we all seem to suffer is autonomic dysfunction, manifested predominantly as postural hypotension.
Mhm.
But we thought, in the scheme of things, we have fully functioning mental capacities, haven't lost our memory, and we're okay with a bit of imbalance and maybe needing to use a walker or a wheelchair. But we're much more worried about what can we do to minimize the impact on the next generation. So I think that's how it affected us mostly.
What do you think you can do to minimize the impact?
Well, I thought as a physician, I had the ability to make some noise about this. And that's one of the reasons I wrote the paper. Let's get more literature out there. Let's get talking to people. Because as I mentioned, I do believe it's underdiagnosed. And I think if it can be, if there's more awareness about it, there may be more diagnoses made. And this may make the push to look for new therapies or effective therapies bigger. If it's a bigger target audience, then pharmaceutical industry may be more motivated to look for interventions that might help. So that was one thing. And the other thing is, talking within families about genetic conditions is complicated. There is genetic counseling out there, and I did receive genetic counseling, and they made me aware of several things. But ultimately, I think it comes down to two variables that determined how we dealt with it with our children as individual families. And the two variables are what we anticipate the psychological impact of doing testing might be on our children, which varies by individual child, I think. And secondly, where even though there's a literature out there on pre-symptomatic testing in autosomal dominant and neurodegenerative diseases, most of the literature refers to a time when active interventions were not available. And in our case, knowing that in each of us the symptoms came on in our 60s and that the landscape of therapy was changing very quickly, those factors weighed heavily in whether or not our children, in discussion with us, decided to go ahead and get testing. So I think it's very individual. And I think the changing background of potentially novel therapies becoming available influences that decision massively.
Can you talk about your initial impressions about the antisense therapy that's currently pending review by the FDA? We're expecting an answer sometime in mid-September. There's publications in the pipeline, I hope, that describe the results of the clinical trial that concluded last year. It's not a cure, but it seems to offer some benefit for people such as those in your family who, as you say, are relatively mildly affected. Is this a sort of intervention that has any appeal?
Absolutely, it has appeal. Clearly, to know that there's at least one company actively, in a very advanced way, working on this condition is wonderful. I had read the preclinical literature that your group had done looking at this intervention in animal models, and that was very striking. And then to hear that the result of the clinical trial, phase 1 to 3, had been positive was very exciting. One thing that troubled me was the fact that the oldest patient enrolled was, I think, age 53. And if it ever came to FDA approval, I wonder whether it would be age limited on that basis. Would someone of 70 years old be eligible for therapy or not, as I and my siblings now are in that age group? But notwithstanding, the prospect of a potential intervention is thrilling. Again, I don't think so one of the family trio has passed away. My sister and I are still remaining. I don't think either of us anticipate we will ever receive this drug or that it will alter the course of our disease. But it does give us great hope to think that if our children are affected and at the time they begin to develop symptoms or approach the age group that we got symptoms, that there may be at least this drug and possibly others or improved versions of this ones available. That's very heartening.
Perhaps I can ask you about a sensitive topic that's rarely discussed, which is autopsies. Is that something you would consider personally, and do you think it's important for the field?
My own feeling is, I mean, there was a policy for a while at some of the hospitals I worked in, a policy of 100% requesting of patients to undergo autopsy. I think autopsy is a hugely valuable source of information, and particularly in rare diseases where there's still a lot to be discovered. So I would be in full favor of an autopsy for myself when I passed away, and I'm sure my sister would too. I think it's a hugely important part of medical science.
All right, I think it's time to wrap up. Aidan, can you leave us with a message for the patient family community about your experience?
Yes. So Alexander disease, when one receives a diagnosis, is clearly potentially devastating. This condition, which is labeled as degenerative and progressive, and when I had seen other family members who were on what appeared to be a far more steeply downward slope than I was on, it was quite depressing. But having said that, my diagnosis was made 5 years ago. Clinically, things have been minimally progressive, and therefore receiving a diagnosis isn't necessarily a terrible thing. I don't know why my condition progressed more slowly than my siblings' condition did. And that's one of the reasons I wanted to highlight variability in the manuscript that we published. I think there's great hope in the future. The rate of progress in intervention in genetic diseases, particularly monogenetic diseases, is fantastic. There are already some therapies on the horizon. I suspect there will be more. So even though it is inherited autosomal dominantly, and there's a high likelihood that the next generation and perhaps even the subsequent generation are already affected, I think the prospect is bright that there will be available interventions that can markedly modify the course of this disease. So it's not all gloom and doom, and we should make the best of things while we can.
I think people will take some hope from that message.
Thank you.
That's all for today's episode of Alexander Disease Research Update. Thanks for listening, and thank you to Aidan for joining me today. Our theme song was written by Charlie Allenson, and thanks to Daniel's Fight, our sponsor for these podcasts. I'm Albie Messing. See you next time.